We'll go ahead and get started with the second lab. My name is Andy Schmidt again from Minneapolis, and I'm the lab leader for this lab on managing challenging non-unions. This is sponsored by Biomet, so at the table in front of you, you see Biomet's bone healing system, which we'll talk about a little bit, and you'll have an opportunity at the end of the time to discuss in more detail. Mohit Bhandari is here, and then also Joe Borelli, Meyer Marmor, and Kyle Dixon was in the room earlier. Presumably he'll be back. But what we're going to do is really just give an overview of bone healing. So I'm going to talk for about 10 minutes just to update you again on kind of the basic science or biology of bone healing. Mo's going to give an interesting talk about what the current evidence in terms of external bone stimulation is. I'm just going to show a couple of cases in which this Biomet system was used in a challenging clinical case. Then we'll have a few minutes just for questions and just discussion at your table with any of the faculty or the Biomet representatives. So again, a quick update on the basic science of bone healing. This is, I'm not a PhD or don't have, my understanding of this is basically that of a orthopedic clinician. Did not have any disclosures, but we'll know the bone is composed of cells and the extracellular matrix. There are three cell types: the osteocytes, osteoblasts, osteoclasts. And again, the extracellular matrix is about 1/3 type 1 collagen and about 2/3 hydroxyapatite. Osteoblasts are the cells that line the surface of the bone and produce osteoid. They're derived from the mesenchymal stem cells coming from fibroblast-like precursor cells. Osteocytes are when the osteoblasts become surrounded by the bone matrix and are trapped in these bony lacunae. Function is poorly understood. They clearly have a role in regulating bone metabolism. And then the osteoclasts, as you know, are derived from monocyte precursors, the hematopoietic cell line. They are multinucleated cells that resorb bone and are primarily affected by parathyroid hormone. So bone has multiple prerequisites for successful healing. You have to have adequate blood supply. You have to have adequate mechanical stability, and these are the things we're used to influencing as orthopedic surgeons. There also has to be an adequate orchestrated function of these cell types, all responding to a lot of signaling molecules, and that's what we'll talk about a little bit. So bone, I always tell my patients that their fracture is already beginning to heal when I see them, because that's really true. The moment the fracture breaks, the healing process is begun. So the fracture itself is associated with the bleeding and the formation of a hematoma. That hematoma is full of growth factors that begin to promote angiogenesis and vasodilation almost as soon as the injury occurs. And the blood flow does substantially increase in the fracture site and the injured limb, peaking about 2 weeks post-injury. The proper mechanical environment is very important. Early stability helps or is thought to promote revascularization. And then after the first month, mechanical loading and the appropriate amount of interfragmentary motion promotes greater callus formation. We know that clinically. Mechanical load and small displacements stimulate healing, but if there's either too much motion or too little motion, we know clinically that the fracture healing is affected. In terms of the impact of this, there are apparently over 6 million extremity fractures in the United States each year. If you assume about a 10% non-union rate overall, the economic consequences of that have been estimated to be a $6 billion economic impact on our economy. So fracture non-union certainly occurs. Obviously, it's an interruption of normal healing, usually due to a combination of biological and mechanical factors. So you can have a poor soft tissue envelope, which affects the revascularization at the fracture site. You can have comorbidities like tobacco use, diabetes that affect vascularity. Infection from either an open fracture or a surgical misadventure contributes to this. And then, as I've already said, abnormal mechanics, which is what we focus on as orthopedic surgeons. When a fracture doesn't heal, there's really 3 broad choices. Sometimes the patient can live with it. So a clavicle non-union, only about half of them are really symptomatic. A scaphoid non-union may be something that a person doesn't seek care for. But most other non-unions, especially in lower extremity, are going to be quite symptomatic and typically are treated with surgery. And so surgery is very expensive. It's often very challenging. sometimes the patient trades one problem for an even worse problem if there's a complication. And so certainly non-invasive ways to get fractures to heal are of potential importance. And there are many different methods to this. There's ultrasound, there's extracorporeal shockwave therapy, and then electric bone stimulation. And there's different types or different ways in which an electric field can be placed around the bone. There's direct implantation of electrodes, direct current devices. There's fields can be induced by electromagnetic or pulsed electromagnetic fields, which is one of the devices you see here. You can also place two electrodes superficially and through capacitive coupling, generate an electric field. And then again, ultrasound is another form of bone stimulation. So bones heal through a highly orchestrated cascade of cellular effects and signaling molecules. This kind of gets at the spatial aspect of bone healing. So this is an image from one of Carl Brighton's papers showing what callus looks like in a long bone. But this is orchestrated not only spatially, but also temporally. So fracture healing occurs through this well-defined phases. The first phase is the inflammatory phase that really begins at the moment of injury when you have the formation of the hematoma, invasion by inflammatory cells, and then the reparative phase is when the hematoma organizes and there's mineralization of the collagen matrix or cartilage matrix that forms through the formation of soft and then hard callus. And again, this is localized spatially as well. So we did some research in our lab on infected nonunions and tried the application of BMP2 and BMP7, and they both produced increased bone formation, but at different places. With BMP2, we saw more formation endosteally, and with BMP7, we saw the bone forming more periosteally. So again, these molecules behave differently in terms of when they are present temporally, but also where they are within the fracture site itself. And then the remodeling phase is the end. This is just a histopathologic slide that shows osteoid forming. And so the mechanism of bone induction includes the chemotaxis and then the proliferation of the appropriate cell types. And then the process of bone induction, typically woven bone is formed and then remodels. And then throughout this whole process, you have increased vascularity as well. Platelet aggregation is one of the things that occurs right away in terms of the hematopoietic or the blood clotting response to injury. But these platelets are just little packets full of all sorts of growth factors as well. And that was the reason why platelet concentrates have been of interest for injecting or surgically implanting at a fracture site. There are numerous osteotropic cytokines. They have funny names because they were typically first described for something else, like the insulin-like growth factors, transforming growth factors. But these molecules are active or play multiple roles throughout the body. And the bone morphogenetic proteins are more aptly named because they were actually first discovered by the ability to form bone as opposed to something else. There's 17 or 18 of these now, poorly understood, but as you know, a couple of them are clinically available to try to promote bone healing. And as I said before, they act in a very specific and very complex pathway, which they have to work with other signaling molecules and affect different cell types. And so this is just probably actually a fairly simplistic artist drawing of how the various cell types, through processes of mitogenesis and differentiation, end up, in response to these various growth factors, form the bone-producing cells. So bone graft is what we typically do to get a fracture to heal. And bone graft or tissue at the fracture site really has different properties. The osteoconduction, which is just the scaffold for bone formation. Osteoinduction, which is the effect that the growth factors have on the recruitment and differentiation of bone-forming cells. And this is really where I think this is the phase where this type of bone stimulation has its effect by affecting the presence and function of these growth factors, and then finally you have the osteogenesis by the cells itself. So again, osteoinduction is the process of this mesenchymal cell recruitment and differentiation in response to the signaling molecules leading to bone formation. So how do electric fields play into this? Well, back in 1953, Yasuda in Japan discovered that when bone was stressed mechanically, the concave side develops some negative electric potential, and the opposite convex side is positive. And then he noticed that when this is done in a living, this is even true in dead bone, but in a living animal, callus would form on the negative side. And so with that observation, he then implanted electrodes into some rabbits and began to run different levels of current through them and found abundant new formation around the negative electrode when he did this. And the quality of bone was varied depending on the type of current that he supplied. So he concluded that dynamic energy, bone deformation, is transformed into an electric potential, and that the latter plays an important role in callus formation. This really was the genesis for all the research that's been done, ultimately leading to these sophisticated devices that you see on the table here for trying to improve callus formation. So again, I neglected to put shockwave therapy here too, which is another form of mechanical energy, but for electric bone stimulation, there's direct current implantable devices, and then for non-invasive devices, there's pulsed electromagnetic fields, capacitive coupling, and then these devices that are so-called combined. They all work by affecting the electrical potentials around the bone. If you implant electrodes, the direct current devices, they cause decreased oxygen tension and increasing pH at the cathode, resulting in increasing proteoglycan and collagen synthesis, bone formation, but this is a very simple example of a direct current device. The pulsed electromagnetic field device, such as you see here, induces a time-varying electromagnetic field that mimics the endogenous fields that are actually seen in living bone normally and results in upregulation of mRNA and protein synthesis. And this is kind of what the signal looks like in these pulsed devices. Capacitive coupling is a way of creating a sinusoidal signal between two electrodes that are placed on the surface. And again, these fields stimulate all sorts of things. And in this case, it's been shown to activate voltage-gated calcium channels, and again, leading to increase in these cytokines that we know to be important in bone healing. And then finally, these combined devices have been shown to affect all these various cell signaling processes, ultimately leading to increases in the levels and function of these signaling molecules. In contrast, ultrasound probably works more through a mechanical stimulation and healing, but again, the final common pathway is the same. It increases blood flow, increases the levels of these signaling molecules, affects calcium and potassium flux in the tissues, and the heating may actually cause some conformational changes to proteins that make them more active, but I'm not sure to what degree that's actually thought to really affect this, but the final common pathway, again, is this effect on osteoinduction. So Mo's going to talk about the relative evidence in support of these, but to summarize this, basically fracture healing is influenced by many factors. We can influence mechanical stability quite a bit by choice of treatment. What we don't have a lot of influence in are the biochemical factors and the signaling molecules, and this is where these external bone growth technologies can play a role. So Mo?
Just by a show of hands, how many of you are or have used a bone stimulation at some point? Okay, great. So a lot of you. And let's say a breakdown. How many of you used an ultrasound device in the past? Okay, and then the majority, I presume, then have used the e-stim. So you're familiar with bone stimulation, or the majority of you are. So the question really is should we be using them? And if we are, which one? And I'll try to tell you that it would be wonderful if we could have sessions in any area where we could say we're absolutely certain. And there are a few areas where we are, but the truth is we've come a long way, but it doesn't mean we have definitive evidence yet around all the indications for some of the therapies we use. But remember, what we're trying to do is get what we believe is a logical answer, right? So some sort of either systemic or locally applied non-invasive or minimally invasive technology to enhance healing, usually in those tough cases, whether it's a delayed union or a non-union. And here have been some of the hope, right? The hope for us has been that it'll be one of these agents, and this is sclerostin antibody, and this has been PTH. And ultimately, bone stimulators have been around. So they've been around in this landscape for many, many years. So the question is, these were supposed to be the game changers, and we're still determining. I mean, there's been some setbacks in many of these. In fact, these trials have been stopped simply because they have been unable to meet their primary endpoint. And we know what's been happening historically with BMP7 and BMP2. So the challenge is, and PRP is still pretty early, right? So people are trying to figure out where its indications lie. So when we think about these agents, ultimately, the one group that has been around for a long time, which is good, which means we've got pretty good data, right? We've got lots of data, we've got decades of data we can start thinking about and evaluating. So just to reemphasize what Dr. Schmidt said, is it's an externally applied, or minimally invasive tool that's to help stimulate healing of damaged tissue, and in the indication that we're talking about today primarily is with delayed and non-unions. Here are the players. We'll focus on really these two. Extracorporeal shockwave therapy does have early data, and there are some clinical trial data and some observational data sets, but I won't focus on that. I'll focus on these two for this morning. But if I were to quantify what I believe, like if you look at everything, and you have a visual, you would probably say from the absolute gold standard, we should use it for every patient, versus poor quality, I'd say extracorporeal shockwave therapy, the data is still emerging. And it continues to grow, and there's some groups that are working hard at trying to get more data. So we're a bit early in that to be thinking about it. I would say ultrasound is roughly about there. So there is moderate quality data that helps us make decisions. And I would say that eStim is right in that ballpark as well, but moderate quality information that helps us. So the question is what's the gap, right? And the gap, as you've known from this morning and from really what we've been saying the last few days, is we need to make sure that the outcomes we measure are not just important on X-ray, but actually lead to demonstratable changes in patient function and quality of life. So ultrasound, it's got approvals for these indications. And just for clarification, we started a trial looking at a very large trial, about 500 patients, looking at the use of ultrasound versus a sham device in operatively treated tibial shaft fractures, IM nailed. And subsequently, during that period, there was this change in ownership or part ownership to Bioventus. And we've done some meta-analyses in the way. And the challenge that we're having, right, and the challenge that puts bone stimulation in this area where we have to be thinking critically about it is, for ultrasound, for example, if you look at conservatively managed fresh fractures, so if we look at non-operatively treated fractures, there seemed to be pretty good signal that there was an acceleration of radiographic healing. And you could see the time could be somewhere around a third, right? So you could reduce the time by about a third to radiographic healing in days if you use it on a in a non-invasive manner in a non-operatively treated fracture. The challenge, though, was in this area, right? Operatively managed fracture. So when you put a device in, whether it's a nail, and these are tibial nail studies, completely divergent results, which made the study we did, TRUST, valid and important. And the non-union data, while encouraging, really was only a few studies of, as you can see here, 21 patients, so small numbers of patients. So that was the action, and obviously we called for more data, and the challenge was that even that patients were coming out saying, well, we can get these fractures to heal radiographically, it was the effect on function that was not significant. And so if the X-ray looks fine, but in fact the patient's no different in terms of their ability to move or activities of daily living or quality of life, we have to be thinking about that, right, in terms of the overall recommendation one might give. So this was the TRUST trial, which was meant to be a trial that was going to help us uncover whether or not bone stimulation in general, in this particular case ultrasound, would ultimately have benefit in patients with operatively treated fractures. I can't speak to it because we're in the process of working with getting a manuscript published, but I can tell you it was terminated, and so you can take into that what you think, but I can't tell you the answer. But anyways, it was terminated. So the thing you should remember from this, though, is extracorporeal shockwave therapy and low-intensity pulse ultrasound. Really, and maybe I'm being harsh by saying no, but I think in general there's limited data, like limited high-quality data, that they actually improve patient-important outcomes, like function. And they just haven't been able to do it. And that's the gap. That's the gap that you're going to face when you have to make decisions about using adjunctive therapies. But the non-union data is observational, and truthfully, because it's observational, meaning that it's a big bunch of case series, there is a tendency to overcall the efficacy of a product when you treat it with that one product all the time. So the 80 or 85% healing rates you're seeing may be an overestimate of the truth, and you in your own practice know really what that number is. It may be half, it may be less, whatever that number is, but you know it's an overestimate. Now, what about eStim? Same story. Yeah, I mean, a systematic review that we did, a meta-analysis 7 years ago, had this conclusion. Basically, we found that when we looked at eStim in general and its effect on delayed union and fresh fractures, that there was significant diversity between the trials and methodological limitations that made it difficult and made our ability to say, well, we're not certain, what the impact of this is. And we certainly can't make a strong recommendation that it works, and we were uncertain 7 years ago. Now, this data was actually grossly misinterpreted by lots of groups, and that's the challenge, right? Is that you write something and you hope that it'll be interpreted in the way in which you hope it. Well, we said we're just not certain. We didn't say it doesn't work. We just said we're not certain. And our certainty was basically because when we looked at the effect, so this was the likelihood of success in healing nonunions was just under twofold, but it didn't hit statistical significance, which basically meant we need more data. If we believe this is true, we need more data to confirm that. I can tell you in the last 7 years that there has been a lot of new trials, and we're currently re-updating this data set. And our re-update of this data set is far more optimistic than that original review was. So in 7 years, there's been a lot of changes. And that is why I've moved the eStim data to be a little bit ahead of the ultrasound, simply because the last 7 years has seen a lot of new publications that have helped us make more inferences about the overall effect. This was the original data set that so you can see this side favors eStim. All the dots are kind of what the results are, and they're mostly on the favoring side, but they had huge amount of variability. They were small studies, right? So they had these huge confidence intervals, and that's why we were uncertain. And now, really what we've been able to do, because there's been newer techniques that you can actually take independent groups. So eStim versus LIPUS would be the ideal study. The question we'd like to ask is, well, which one do you use? Do you use LIPUS or do you use eStim if you're going to use a bone stim in general? And you were never, and despite, I can tell you we tried, we were unable and unsuccessful to have an eStim company agree to, and an ultrasound company to agree to randomize their products against each other. And you can imagine the reasons why that would be a challenging marketing tool if one of the trials would show no difference, or in fact if it showed inferiority of one to the other. So, but we can do that, right? So there are tools that we have now called network meta-analysis. And basically what it allows us to do is take studies that have looked at LIPUS versus placebo, eStim versus placebo, and head-to-head, and we can do our own indirect comparison. This is called a network meta-analysis, and it's a word you're going to start hearing more and more because it's becoming more and more popular. So when we do a network meta-analysis, this is again, albeit a very early, this is published data, so I can speak to this. When you look at this, you see that for fresh fracture healing, it's on this side favors ultrasound, this side favors eStim. You can see that there's a trend, even though it's a trend, it's not significant. It suggests that ultrasound may have a slightly stronger effect over eStim in fresh fracture healing approaches, and largely because there's probably just limited data on both sides. But eStim seems to have a trend towards a stronger effect than ultrasound when it comes to delayed and non-unions. And again, this is not significant, but again, if you were betting, you might say it's favored. And that's all you can say, and maybe you could say it's trending, but it's not significant. So in other words, the purists would say there's no difference. And if you're looking at the numbers, you'd say, well, one seems to be one way, one seems to be the other way. So that, you can take it or leave it as you wish. So the point is, if you're using one product or the other, I don't think it truly matters at this point. Maybe more evidence coming out that might suggest that there's a difference. The challenge is, though, is that this paper was published, and this was one of the comments that came back. And it's been very, very appropriate to this morning's discussion around outcomes that Dr. Schmidt presented, right? I mean, we can see now that this doesn't make a lot of sense, right? Like, to basically make the statement that a X-ray is far more important to patients than how they function, is really it's a misstatement, right? And so it's that kind of stuff that's going to be challenging, right? And that is the reason why that type of philosophy is not going to promote, better understanding of these products. It's going to be really understanding functional outcomes. And so that's what we're trying to do as we move forward. So remember, there are about 3 players in the area. You can expect some benefit in radiographic healing. Remember that there is still limited, if any, evidence that this impacts patient function at present. And remember that non-union data is still observational. So in other words, it's likely an overestimate. So if the numbers you're seeing, you can be pretty reasonable. I mean, if you're absolutely believe it works, then you can say it's absolute what it is. But most of us would probably tend to cut that number down a bit from what's reported because of the nature of the study design. But it does appear to favor eStim, and that's kind of where we are today. And so today, the hope is that you take a look at some of this and move forward. And all of this is available on the Ortho Evidence site, and it's being offered to you free. So please take advantage of any of the information on that site as a member of this course.
Okay, what we'll finish with is just a quick review of some cases. These were provided by Biomet. So these are clinical examples where a clinician treating a challenging fracture healing problem used this system to positive effect. And they're just examples to see where they're used clinically. So this is a 50-year-old male who had a displaced comminuted midshaft clavicle fracture while skiing, treated for a month in a figure of 8 split and then put in a sling. This is the x-ray at a month showing very little callus formation. And then at 3 months post-injury, his fracture was ununited and he was still having pain. And at that particular point, treatment was initiated with a Biomet bone healing device, and then 3 months later, he returned pain-free with good callus formation at the fracture site. Here's an example of a complex subtrochanteric fracture in a 66-year-old male thrown from a horse, treated with a blade plate, and was told to begin weight bearing 8 weeks later, and was seen at 6 months with continued pain. Apparently revision surgery was offered, but the patient declined, and so minimally or non-operative approach was recommended, and treatment with the capacitive coupling device was initiated. And then at just 2.5 months after that, you can see improved callus formation across the fracture site. And then after 4 months of treatment, 10 months post-injury now, the fracture looks like it's well healed. And then a final case example is this one, a woman with a segmental tibia fracture after an auto versus pedestrian accident. This is the immediate post-op x-ray, so you can see the distal fractures aligned really pretty well, but the proximal fracture has a little bit of distraction, flexion, and translation, so a fairly large fracture gap. We can talk about the timing of when this treatment should be initiated, but here this patient was followed, and for 10 months the distal fracture healed, but the proximal fracture remained ununited, a little callus posteriorly perhaps, but pain at the fracture site, pain with weight bearing. And then at that particular point, treatment was initiated, and then 5 months later, the patient had much more callus, including anteriorly, and more importantly, her symptoms had resolved and she was weight bearing comfortably. So again, just some examples. Interestingly, we were talking between cases. A couple of those are fractures that you might predict a non-union in. This gets a whole philosophical discussion. In Minnesota, the payers won't pay for any bone stimulation device until 3 months have gone by. And you could argue about the economic impact of that, because I think we as surgeons can predict that some of these fractures are going to take a long time to heal. Is that something you can talk to the Biomet reps in the room? This is probably different from city to city, state to state, insurance plan to insurance plan, but represents one of the practical challenges we have in trying to intervene with a technology that definitely seems to have an effect that could benefit some of our patients. So we have until 11:15. So 11:30. Oh, okay. I'm looking at yesterday's labs. Yes, we have about 10-15 minutes left. So please ask questions if you want right now. At all the tables, these are real devices. You can turn them on. You can play with them. You can ask the Biomet reps who are here for information, and then all the faculty will kind of roam around the room as well. Thank you for your attention.